I would like to provide you with the risks and benefits of cataract, glaucoma, and refractive surgery. Cataract surgery has improved over the last 70 years to what is now a 3 to 5 minute surgery that is more comfortable than a teeth cleaning, and you can immediately go home afterwards and engage in your normal activities. In the past, it was more common to encounter complications during surgery. However, presently, these complications are exceedingly rare. The two complications that will result in a degree of vision loss are suprachoroidal hemorrhage and endophthalmitis. In other words, bleeding behind the retina and infection. The risk is 1 in 3,000 or 0.03% for suprachoroidal hemorrhage and 1 in 2,500 or 0.04% for endophthalmitis. These numbers are from 10 years ago, and the estimate for endophthalmitis is now 1 in 10,000 or 0.01%. I estimate that the risk is much lower for clear lens exchange. Every other complication will not compromise vision, as the eye can naturally heal, or we can offer a solution for the problem. All other combined complications are much less than 1% in modern-day eye surgery. As with any surgery, there is always an element of unpredictability, despite the best preparation and execution. But cataract surgery is the most controlled surgery among all surgeries performed in the world. The most common complication is called a refractive surprise. This is where the lens does not perfectly focus light on your retina to create a clear image. While the measurements we perform gets us excellent results 90 to 95% of the time, there's one element that we cannot predict that is called the effective lens position. This is the position that the intraocular lens eventually settles in. Let me demonstrate. Here's a representation of the cross-section of an eye. The triangle here represents the lens on the vertical side, right here, and its ability to focus light on the other two edges of the triangle. Ideally, this triangle meets the retina in the back of the eye perfectly, right here. If the lens settles and scars into the tissue slightly anterior to where we estimate, then it will cause a myopic shift or a slight nearsightedness. If it shifts posteriorly, it causes a hyperopic shift or a slight farsightedness. We can easily tolerate a half diopter in either direction. It is in excess of a half to 1 diopter that we consider two solutions. One, we can do a lens exchange if we encounter a hyperopic shift, a posterior shifted lens. And two, we can perform refractive surgery such as LASIK or PRK for myopic shifts. Most of the time, if your vision is blurry after surgery, it is likely that you are experiencing a brief period of dry eye that blurs your vision or swelling in your cornea. This is common because of the iodine antiseptic that stuns your goblet cells, which are responsible for lubricating your ocular surface. We will follow you very closely and determine if you need an enhancement after around 6 weeks' time. Another mild complication is called a subconjunctival hemorrhage. You may notice some blood on the white part of your eye after surgery. This is akin to a bruise. It will not harm your eye or your vision and should go away in 2 to 4 weeks on its own. This is common in older patients and those who are on anticoagulation. Sometimes patients will notice a flash of light or dark when they look around after surgery. This is not concerning if it is not perceived with the eyes closed. It is called a dysphotopsia. This is because initially the lens jiggles slightly when we move our eyes around. The light catches the square profile of the lens and can give unwanted arcs of light. Don't worry, the lens is designed to scar into the tissue when this occurs. The lens will no longer jiggle and you will no longer notice this issue. This takes around 1 month time. Another rare surgical complication is called a posterior capsular tear. This occurs during surgery when the 4-micron thin tissue called the posterior capsule is damaged during surgery and can no longer be a barrier for the vitreous jelly in the back of the eye. We fix this issue by removing the jelly that comes forward, because if not removed, this results in higher risk of eye infection and retinal swelling and retinal tears. This lengthens your surgery duration by 10 to 20 minutes and may lengthen healing time, but your vision will not be affected ultimately. Posterior capsular opacification is a very common phenomenon. This is to be differentiated from a posterior capsular tear. A posterior capsular opacification, or PCO, is induced when the hydrophobic acrylic or silicone intraocular lens causes the transparent barrier called the posterior capsule to haze and scar. This occurs to almost all patients who undergo cataract surgery within 6 years. Its onset is sooner for younger patients. It is often described as a secondary cataract because it causes the same symptoms as cataract. This is easily treated with a 10-second laser procedure called a YAG capsulotomy, where we remove that opacified tissue behind the lens to restore your vision. If you feel like your vision is becoming blurry months or years after surgery, it is likely to be a PCO. Occasionally during surgery, the iris can become damaged. This is usually when the patient takes certain medications, for example, tamsulosin, otherwise known as Flomax, and develops a poor dilating and floppy iris that can get caught up in the removal of the cataract. The damage usually heals on its own or can be surgically repaired if extensive. You may experience a duration of photosensitivity, but it would not be expected to affect your vision. Cystoid macular edema is a rare swelling of the retina. This is usually in patients who are diabetic or have extraretinal membranes or other retinal issues or prolonged inflammation inside the eye. This swelling usually goes away on its own, but can also be treated with eye drops and, on occasion, injections into the eye. Retinal tears are exceedingly rare. Often they can occur in long eyes with a retina stretched thin. A retinal tear is usually unrelated to surgery, but is a lifetime risk factor for patients with long eyes or retinal pathologies. It is treated with laser. If untreated, it can lead to retinal detachment, which is fixed surgically. A retinal tear will manifest as constant flashing lights in the periphery of one eye that does not go away when you close your eye. It is also common to see a significant amount of floaters, which indicates bleeding. You must call us if you are experiencing the signs and symptoms of a retinal tear, so we may refer you to a retinal specialist for immediate repair. Finally, in very rare cases, decades after surgery, the lens can dislocate because the thin tissues that surround it weaken and give out. This will cause profound changes in your vision and is often due to something called pseudo-exfoliation, or in rare cases, dead bag syndrome. The vision is fully restored with a surgery that removes the tissue and original intraocular lens and replaces it with a scleral fixated lens. It is very common to feel apprehensive about eye surgery. I hope that this list does not frighten you, but rather lets you know about all the small risks that we are prepared to fully fix if on the off chance we encounter them together.